Welcome everyone to the webinar for the National Correct Coding Initiative edits and the modifiers that can be used to override them. One of the top denials through our data system shows that modifiers is an issue and that working with the National Correct Coding Initiative edits related to those modifiers is one of the issues. So we put this together to help address the data. I want to remind you that I am Tom Ryan with Provider Ocean Education, and I'll be your presenter today. Today, I am joined by Aline from my team. She's going to help with the chat. She's going to give you some different resources. If we have a question and I need her to look something up for me, I'll give her a prompt to do that. So she'll be the one monitoring the chat and getting us through that process. Our objective today is to determine if you should use a modifier to override the National Correct Coding Initiative edits and whether or not that would be appropriate according to the Medicare system. I will tell you we had a lot of questions and some of them were not related to the modifiers relating to NCCI or the National Correct Coding Initiative edit. I can't go through all modifiers. I will tell you that we're planning to do more education based on different modifiers throughout the year. So in particular, there were some modifier questions on evaluation and management, some modifier questions on advanced beneficiary notice of non-coverage. Just continue to watch more information as they come up. One other thing to go with that objective, we talk about avoiding the Medicare denials. We talk about reducing costs and making sure you're using them correctly. This is only for traditional fee-for-service Medicare. In other words, Medicare Part A and B. This does not apply to Medicare Advantage plans. I did have a few questions come in where the provider mentioned Medicare Advantage plans. Those plans may not be affected by NCCI. Each plan is unique and different, so I can't talk about that because of their uniqueness and differences. So what's on the agenda to get us through this information today? Well, first, of course, there's an overview. I want to give you the basic information. I do not want to lose the people that are new, so we'll talk more about that. Then it's, are there modifiers that can affect these types of edits? And the answer is yes, and we're going to take a look at some of those modifiers. Last, we'll show you the CMS website resources which could help you. Again, I do want to encourage you to add questions to the chat. I think it's the best way to make sure you're getting what you need out of the information. If you're just here to listen, we welcome you too. I want to remind you to review the disclaimers at the end of this presentation. One of those disclaimers is from the AMA, because we do use their modifiers and some of their CPT codes in our examples. Let's get started with an overview. Now, the overview is designed for those that were new to Medicare, and I will tell you there were a lot of you that in your registration information indicated you were new to Medicare. So during this time, as I go through the overview, I will provide you a lot of information in a very quick manner, but I want you to use the chat feature. We don't want to leave anyone behind, and I don't want to have anyone not understanding what's going on, because when we get to the next couple of sections, it can affect your understanding, okay? So to start with the overview, what is the reason or the purpose for NCCI? Well, NCCI is the National Correct Coding Initiative, and it encourages accurate coding. It prevents improper payment, which saves the Medicare trust funds money. It reduces administrative time and expenses, and it saves the patient money. So why is this important? It's important to make sure that Medicare is only paying for medically necessary services and in the proper manner. That's part of what the Correct Coding Initiative establishes. These edits are national, which means they are CMS edits, which means they would override a local edit if it contradicted it. Some of these edits are updated quarterly, and we'll point that out. For instance, the procedure to procedure edits, because there is more than one type of edit. So we want to make sure everyone is aware of that. How does CMS give us these edits? Well, us as a contractor, we get a feed from CMS that contains these edits. It's the same information, however, they publicly post to their website. On the website, they post Excel files, and we're going to take a look at these later. So it's not like these are hidden edits or other things like that for the most part. And we'll explain that when we get into the edits and explaining which edits are affected later. One of the concepts that a couple of people asked on was the same provider. And one of the, I think the reason that this was asked was because they were asking if it is physically one person, or what does Medicare mean by that? So when you're within the Internet Only Manual or the daily operating instructions for Medicare, the concept of same provider is not always one person. Yes, it does mean one person, but it also means any physician or qualified healthcare professional with the same specialty and subspecialty or subspecialty. Okay. They are considered part of the same group when defined by a tax ID that is the same. So making that a little bit simpler. Any physician or non-physician practitioner with the same specialty in the same group as defined by tax ID will be considered one person, one provider for Medicare. Okay. So when you go to put the claims together, you have to make sure you follow that definition to see whether or not some of the NCCI edits will actually apply to you. But keep in mind, again, it's not always just one person. It's not one human being. It can be multiple just depending on who's practicing together. I was asked specifically, does same provider affect lifetime benefits? Well, lifetime benefits are not typically within NCCI edits. Yes, this does. A lifetime benefit is just that, once in a lifetime. So whether or not it's the same or a different provider, you're still not getting paid for it because by definition, it's a lifetime benefit for Medicare. Let's talk a little bit about the 3 types of edits that fall under the National Correct Coding Initiative. The first one is what we commonly hear people refer to when they say CCI. This is procedure to procedure or P2P code pairs. These are designed to correct or to detect incorrect code combinations by having 2 codes. One is payable and one is bundled into that code and may be modified at times to make a separate payment. We'll show you the actual tables that tell you whether or not you can use a modifier on the other code. Okay, so one of those codes is primary and will always be payable separately. The second code when billed with it is a additional code, not an add-on code, but an additional code, and that code may bundle into it. So it's 2 codes. Same provider has to bill them. Now there are certain codes, again, once in a lifetime codes or other things that don't apply to the same provider, but for the most part they do. Next is the medically unlikely edits. I jokingly heard this referred to as the medically unlikable edits. That's a good terminology for some people, but really these edits are designed to avoid excess units of service and payments for those. Now these edits are unlikely, not edits that say, oh, you can never be paid for it, not things that are impossible. An example of an anatomical edit that is unlikely is that a patient will have more than 10 fingers. It is possible, but it's kind of unlikely depending on where you're at from the country. So we do set an MUE of 10 and say, hey, do you want the remainder? Now you have to tell us there's more. Would that makes sense to everybody? All right. There's also add-on code edits. Now, these are very simple. When you read the CPT book or when you read the HCPCS guidance and it says this must be billed with this is an add-on code for that service. That's what codifies them. These edits codify them. CMS then uses these edits to tell us as the contractor and the system maintainer what should be added for the add-on code. So that's the third kind of edit. These are not something that a modifier will override at all. It's not even possible. I do want to point out that on the slide, if you're on this slide with me, there's a link on the bottom. It is a hyperlink, and it will take you to the CMS website for the National Correct Coding Initiative edits. Later, I'm going to show you step by step how to get there. Okay. Let's talk a little bit more about the two types of edits that are overridable with a modifier. Okay. For the P2P tables, so there's two different tables under the procedure to procedure edits. These are divided for billing purposes by the systems that Medicare uses to process claims. The first one is the multi-carrier system, MCS, and is for 1,500 claim forms or 837P electronic transaction. These are practitioner edits labeled by CMS, which is what's first mentioned here. Okay. The second type is outpatient hospital services under the Outpatient Code Editor, or OCE, in the Physical Intermediary Standard System, or FIS. FIS is the UB04 and 837I claims. Both sets of edits read the same. It's not that you're going to have to read them any differently, so we will show you that in a little while. But you do have to make sure you're using the right one, because some of the professional services are not in the outpatient hospital code editor. Why would they be? That's the question. Why would they be? Some of the facility codes don't make sense to be in the physician one. Again, facility code, why would they be? So you want to make sure that you're looking at the correct set of edits. And again, we will show you those in just a few minutes. MUE has three sets of edits. The first one is for physicians and practitioners, just like we defined above. The second one is for outpatient hospitals, just like we defined above. And the third table is actually for durable medical equipment. We will not be looking at the third table because we do not process claims for that. Therefore, we will not be offering advice, answering questions, or looking at that table. The other two we do, and so therefore we can look at the information within it, and CMS allows us to speak on those. The next section, we're going to look at some of the modifiers. Now, people ask all the time, are there certain things and should we look at certain things? Which modifier can it be? We're going to answer a lot of those questions when we look at the resources available on the CMS website. But I want to define for you some of the modifiers and give you some information about these modifiers to make sure you're using them correctly. Okay. We do use the catchword potentially override the edits. The potentially override the edits refers to documentation that you need to have in place. The documentation must support that you need an additional payment. Well, what types of things would that be? How about on a different body part entirely? That's an anatomical modifier and absolutely will override these edits. How about significant more E&M work? Again, that's an anatomical modifier, and I'm sorry, that's not an anatomical. That's a type of modifier that would be appended only to an E&M code to show that we've done more work than. Lots of times used with things like surgeries and certain things like that. Also, some of the E&M modifiers to override the incorporation into the surgical procedure will override the CCI edits. So lots of things going back and forth, and we're going to get into some of that next. First, I wanted to give you just a few pages that will help you with choosing your modifier. Okay, NCCI Modifiers is going to be our first link, and I'm just going to select it so you can see what happens here. This should bring us to the CMS website. You can hear me stall a little bit there we go. And it's going to bring us to one of the FAQs in particular on the CMS website. Again, I'll show you how to navigate to this. But this is where we get a lot of our information, okay? On this section, notice there are actual links to other items that may help you. I do always recommend the NCCI policy manual. I'm just going to scroll through so you can see some of the different types of information you may need. So some of the questions that were asked, we're going to do our best to define based on this. information, or it may actually reference back to a question. Other ones will give you our system information for it. All right, proper use of modifier 59, XE, XP, and SU. This is actually a Medicare Learning Network booklet. We had a lot of questions come in on this, so I thought, well, okay, we're going to get to that one in a little while. Please take a minute to look at that. Again, as a reminder, this is also referenced within those FAQs. I want to say it was on 2 or 3. So please take a look at that. If you don't want to have to try to remember it, drop into this sheet. It's right here. Oh, actually, it's in question 1. I apologize, but it's towards the bottom of question 1. Okay. So just a lot of good information contained so far, and we haven't really got into a lot of the detail of it yet. All right, the other one is the WPS Modifiers page. Now, I do encourage you to look at this one. It talks more about some of the system edits and the items that we want you to know. So while CMS may give you general guidance, they don't process within the system. They don't write the edit that goes into the system. There may be things written for the National Correct Coding Initiative edit that are written on a national level, but there may also be additional information supplemented by a contractor. So if you want to know more about this, I'll just show you real quick and then we'll get back to this. Here's the WPS government website. It's our website. J5, J8, this is what's applicable to you. Line of business part A, which is billed on a UB04 or 837B. Line of business 1500, or line of business part B is a 1500 or an 837P. So are you billing on a UB04 or 837I? You will always want to make sure that you stay in the line of business part A as we have it labeled. If you bill on a 1500 or 837P, then you want to go into the line of business B. This is important because, as I explained earlier, sometimes the edits are different. So some of our advice on modifier usage, some of what happens within the system can be different. I'm going to go to part B under J5, which is Iowa, Kansas, Missouri, Nebraska. To show you these modifier fact sheets, I can look it up, or I can simply go quick links and select modifiers. Okay, it's right here on the bottom. Now, if I do want to look it up, I would go Topic Center, Claims, scroll down and open the accordion. For modifiers, it says one item. So go ahead and select that item. This is the landing page for modifiers, and you can see we have a variety of different pieces of modifier information available to you. I wanted to show you that because, again, if you know a modifier, you're looking for something in particular, you can always come back and check this out. It might have some additional edit information that you don't have necessarily from CMS. All right, let's get into the modifiers that will override the National Correct Coding Initiative edits. One of the biggest modifiers is the RT and the LT. It is your side of the body. Now, why is this so important? Well, first, when you're using this modifier, please do not add modifier 50 for bilateral. It is either right, left, or bilateral. Also, read the description within the CPT code, and does it have certain pieces of information in it, such as right or left? If that is the case, it is not appropriate to use these modifiers because the description defines it. How does this happen with CCI, also a duplicate edit? What can happen is if you do not append the RT and the LT, there are times when future claims will come in and they will automatically deny, saying, wait, we've already paid it. It's done. Well, the reality is that provider did one side but not the other, but was paid for both. So the 150% payment applies, like a modifier 50 payment adjustment would apply. So really, it just depends. Again, don't apply RT and LT when the description claims bilateral, when the description claims right or left. Now, for an NCCI edit, sometimes you'll have a number within that says, hey, you can only do this many, and that's a medically unlikely edit. By applying an RT and LT, you're telling us that, yes, we understand we did X amount, But the reality is we did that because it was two separate sides of the body. And that's where you want to make sure you're using it correctly. Okay? Also, it can avoid duplicates, just so you know. Not related to NCCI, but RT and LT can avoid a duplicate. Same thing with an anatomical modifier, and I gave you four slides for anatomical modifiers. Okay. Anatomical modifiers are things like the finger modifiers. Which finger was the issue with? Well, this is important because if it's described as an individual digit or something similar to that language, then we have to know which one it applies to so that we know whether it should be, we should be expecting more units of service. Also, the same procedure can't always be done on the same finger. Sometimes it can, it just depends. Sometimes it's a claim edit, which would be for procedure to procedure. On this claim, you can't do this. That means that when you get to another claim, if you have separate claims for separate dates of service, you could do it. So we can only do this once per day, or we can only do this blank per day on this claim. Okay, now what do we do? That's where some of the finger edits help us to understand what we're highlighting, what we're looking at. And again, it's an anatomical. Which body parts is being done? Okay. Also, same thing. Here's toe edits. They are billed very similarly. So we want to make sure you're well aware of the toe edits as well, and making sure that the TA, which if you notice is by the right big toe, just like with a finger edit, it was by the left thumb. That means all. So the FA or the TA, it indicates all. You're doing all 10. But these are also ones um, that do have some MUEs associated, and they'll say 10. And by putting a TA on there, it will not override it. A lot of the MUE 10 edits like that would say, okay, I've got 10 different modifiers I could use. You're going to wind up doing an appeal. Even though you say, wait, I could have modified it, except how is that modifier going to indicate more than 10? And people have asked us a couple of questions on that, and it is genetically, again, possible to have 12. So, eyelid modifiers. Now, eyelid modifiers are interesting because they do designate which eyelid you're working on. Some people will have all eyelids worked on, and that's okay. Some people will not. Some people may have a right or a left worked on. And when we say worked on, one example of that would be a blepharoplasty. Just there are other services, but that's just one example. So you want to tell us which eyelid you did it on, which one was swollen, causing vision errors, typically E1 or E3, typically. So we want to know so that in the future, if someone said, well, I did an E1, and then 6 weeks later they did the E3 to allow the patient a little bit of comfort and healing time, depending on the patient's medical conditions, that may be appropriate. We don't know that, but we do need to know which one they're doing it on. So hopefully that makes sense when we talk about things like that. Also, there are a lot of cardiovascular procedures that require the chamber of the heart. You know, where does it go? What does it need to be done? Or what are we doing with this? So we always recommend using the cardiovascular modifiers on this. This just helps us separate it all. Oh, before I leave this, and I should have talked about this. The TA, is it used for all, like, so if you're looking at this, or does it just represent this big toe? My understanding is that this modifier would represent all. I do need to do a bit more research into that because if I remember correctly, it was all of them. But it's been a while since I looked at those modifiers, so we'll get back to you guys with a little bit more information. Not sure if Aline wants to try to dig that out while I am going on here. All right. Global surgery modifiers. This is one that's interesting for a lot of people because The global surgery modifiers are not necessarily about NCCI. They are about separating something from within a global procedure. So there are additional criteria. So they could be something that applies, but not always. And so it's a little bit harder. Um, Then like just, oh, I looked up a CCI and I'm good. Because, oh, now you've got to see, wait, does the surgical procedure allow for a modifier? And there's a variety of different surgical modifiers that can be used. So we really wanted to remind everyone that global surgery in and of itself is a separate realm of area. While many of these modifiers are similar or actually the same as NCCI modifiers, there are also some that will require you to look a bit further on another document. Okay. So I don't want to like take away from global surgery, but it's a separate concept from the National Crowd Coding Initiative at it. All right, a little bit more on modifiers. First, modifiers must be justified in clinical circumstances. What does that mean? You have to document the reason. If you don't document the reason, then it is not justified. One of the things that happens is we can't always pull out from the documentation what the reason is. In that case, if you're trying to send in the documentation to prove this, whether it's through an appeal or a medical request, medical documentation request called a ADR, additional documentation request, you may need to help us specify what it is, just so we know, and say, okay, on page 4, paragraph 3, this is the statement that shows that, or this is the information that shows that, or you may need to go to paragraph 5 and read the entire paragraph, because sometimes the documentation to us or to our medical reviewer is a bit on the convoluted side. Not that it's written convoluted, but some of you have also seen where it is very written convoluted. Also, within the documentation, we actually had someone that used a lot of acronyms in other items, and we were like, I don't really know what that is. Their coder was really good at making sure that she gave us what she called her Bible. And it was just something within that explained anytime they use this acronym, this is what it meant. Anytime they use this, this is what it meant. Now, she didn't provide the start to finish. She would give us various pages of it and help explain what those acronyms were. That's a perfect example of what to do there. Okay. Separate encounter specimens or anatomical sites. This is what we're looking for to be documented. Why is it separate? What makes it separate? It's not just, hey, well, it is. Well, it doesn't always work that way, especially when it's a separate anatomical site and they don't document that, or they don't document that they did both the right and the left. They're not justifying what they're doing in that way. Someone asked specifically, so I put this bullet in there, is are all modifiers going to be used, or can all modifiers be used to override NCCI? And the answer is no. There are modifiers that have nothing to do with an override of NCCI. They're purely informational. I guess the easiest ones for me to reference here are things like GA. I have an ABN on file. It's not going to override NCCI. GY. That service is not payable because Medicare said no in the law. Well, if the law says no, it's never payable. That has nothing to do with any of these. So those are just a couple that pop to my mind to make it super easier. So if you're asking me, are all modifiers used within this? No. But that's also why CMS wrote a specific FAQ on it, okay? So what is the purpose of the modifier? The purpose of the modifier is to bypass the edit when it's allowed. Okay, that's what it is, when it's allowed. So how do you know when it's allowed? Well, that's where we got to get into some of our resources, which we'll go to in the next section. I did see some clarification. Aline, what was the clarification coming in from people? Oh, I see it. No, I don't. Oh, the TA modifier indicates great toe, left foot. FA is the thumb for left hand. So, okay, this is a good question, which also then leads to why did someone ask the question later on about modifier 99? For those of you that don't know what modifier 99 is, it's not a commonly used modifier, but I don't want you to think it could never be used. On a claim form, you can put 4 modifiers next to the procedure code. That's just the limit. Well, what do you do if you do 8 procedures because you have 8 different anatomical sites? such as 8 fingers. Then you would use the modifier 99 and you would follow instructions for that, which tells you that the other modifiers are placed within the narrative on the claim, the comment section on the claim. And our goal is not to limit you to 4 modifiers. It's just that's what the claim form limits to. So hopefully that does make sense. Okay. And thank you for that clarification, Aline. That really does bring the other person's question into focus. So. All right. During this next section, I'm going to warn you that you guys have slides, and so, slide 19 and 20 will cover the PDP examples, just the information I'm going to go over, but I'm going to use the CMS website to show this to you in the actual files. So hopefully that makes sense. I'll try to reference the slide that you should be on to kind of help you out here. Okay. So step 1, let's go back. Let's go back to the CMS website. Remember I said I'm going to show you how to navigate versus just, using a hyperlink. So to reach the files in general, you do have to go to cms.gov and then select the first link under the logo cms.gov or under the verbiage cms.gov. This is the term Medicare. When you're inside Medicare, go down to coding and billing, slide to your right into the next column, which will change. And then you're looking for the 5th item down called the National Correct Coding Initiative Edits. For those of you that are wondering why I'm trying to say like 5th item down and all of that, we do have a couple people that we show on the phone, and I want them to be able to follow me along, even if they can't see what I'm doing. Okay. So I've selected that, and it'll bring up the Medicare National Correct Coding Initiative Edits. There's a lot of information on the CMS website for this. CMS does talk about how to submit an appeal with these edits and other pieces of information. Someone asked about filing a claim appeal. That's not this how to submit appeal. Okay. That is follow our website instructions because we are your Medicare administrative contractor. What this appeal is for is if you don't agree with a National Correct Coding Initiative edit and you want it to be reconsidered. That is what you will see here. So hopefully I explained that well enough. Otherwise, you can take a look at the different pieces of information. Okay. So we've navigated to that. The slide 19 and 20 are about PDP, which is procedure to procedure edits. And so we want to look at that, but we want to look on the left navigation bar in the first set of information, and it says the National Correct Coding Procedure to Procedure or PDP edits, and it's the last link within that just above the announcements. So we'll select that. When that opens, you can scroll down, and remember I said there's going to be 2 types. Here's in the body, which is on the right side, and you'll see hospital and practitioner edits. Again, they both read the same, they use the same columns, they do all of that different pieces of information. So you can pick either one. I'm going to just open up these practitioner edits, but that's just purely for the example. I think it's a little bit easier to have that happen. So, okay. So we select those edits, and they're going to open it in a zipped file. And the zipped file looks like this. Then the Excel file looks like this. So I apologize, I was just stalling while it was making sure everything was opening. Now this is what's nice about these sets of edits. It's going to give you the payable code. Always payable. That's column A. What bundles into that code is in column B. So this code will not be paid when billed with this code during this time frame. Okay. Now, one thing to remember, if a procedure code changes, that's why you're going to see a termination date. If you see a deletion, or I should say a deletion date, I apologize. So here you can see they were active for about a year. Something may have changed. There may be a manual instruction change, things like that. When this is no longer active, you will actually see a 9 applied to it. And that means that this code should not have ever been active. This is just, it's not applicable. It should never have been. But it was a code pair combination that was on there for a period of time when in review, when in the NCCI reviews, which is the appeals, it should not have been active. So that's a 9 in the modifier column. The other two are 0, which means no modifier will override this edit, or 1, depending on the documentation, a modifier may override that. And that's up to you to choose the modifier based on the documentation. Choose the modifier that best explains your documentation. That's what CMS is looking for in this case. This just tells you where the edit came from, the rationale for it. So hopefully that all makes sense there. That's one set of edits, and I'm just going to minimize these and get them out of our way. So that is the procedure to procedure edits. The other set of edits that are modifiable are, again, the MUE edits, which if you look directly above the link that we previously selected, second to the top in the left column, you'll see medically unlikely edits. Again, as we scroll down, there are your 3 edit tables. For this purposes, let's just throw open the practitioner edits again, which are going to open and look like this. Now, again, if your zip software looks different, that's normal. If you have a different zip software, this is just the one that we have that comes with our computer. And then our edits will actually look like this. One of the questions that came up with this file I want to address before we get any further into it is every single MUE listed on this file? The answer is no. CMS has stated that some of the MUEs are not listed due to fraud and abuse issues or for other protective reasons. If it's not on this file, please don't call our customer service and ask for it because we will not be able to release it. CMS, on the other hand, does state that if they've given it to you somewhere, you need to go there to get it, and that's what this file is. It's where do you go to get the edit. So with this, you can see it's got a variety of pieces of information that are important. We're going to move on here. Again, we're on slide 21 and 22. 21 and 22. Couple of things to keep in mind. The procedure code is the first one given and then a value set. So you can see just within our couple of values here, if we go to line 14, we'll see a value set at 2. Now, again, a lot of these are things that can be modified. And if not modified, they could be appealed. It just depends, okay? So we move over and we find out that this one is a data service that it's set by clinical in nature. Then you also have data service that it's set by policy. Policy would be code descriptors and CPT instructions. In other words, based on this code descriptor, you can only build one. If you need to build more than one for any reason, we do need you to do appeal because the code descriptor as written only allows for one. If you come back down here, data service clinical, nature of the analytics. Okay, we don't have much to say on that except, hey, this is what should happen with it. I do want to see if I can find one in this column that has a 1. Here we go. And so one of the things that comes up from time to time is that in this column you have a line edit, which is 1 line, and on that line you can append up to 4 units. Okay, that makes sense. But what do you do if you need 5 or 6? You append a line with 4 units and a second line with 1 or 2, 5 being 1, 2 being 6. The second line then gets modified. That's a line edit. It's a little bit different. And so what we really want to do when we look at that is to make sure that you're using the appropriate type and whether or not a modifier can be appended for that. Because with an MUE, there are times when it'll come back and say, hey, this modifier is not allowed. What's really looking at from CMS perspective is they want that clinical documentation and justification, which means you need to do an appeal. We didn't make that decision that the appeal is the way to override it. CMS did. So lots of different things you can kind of take a look for. Here's some CMS policy stuff. Again, you'll see 3. Not sure what else people would like me to look for. Here's one that's 250 per line. And to be clear, an add-on code can have an MUE edit. It can have an MUE edit. Just because it's an add-on code doesn't mean we can't limit the number that you can or the units that you can build with it. That doesn't they don't become exclusive just because, oh, it's suddenly an add-on code. It doesn't work that way. Okay. All right. The last that I did want to just kind of mention real brief, I'm going to jump back to the website here, is that if you go up, you can see the add-on codes. Remember, these are from the different books, the CPT manual mostly. But what's interesting is that this is just the codification of that manual. This codes to this, you must have this and this, and it's just those same things it's going to give you. It's not going to give you a lot more information. So if you're familiar with that from the manuals, this will help you. Okay. Let's see, did I miss? Okay, so let's go back to the PowerPoint and get caught up on that, because of course we're a few questions ahead, or a few slides ahead on that. Oops. Let's see, where are we at? PDP, MUE. Sorry, I had a second there where I couldn't get my fingers to work. One of the questions that we got was, where do we put the modifier? No, I'm going to just assume here, and this may be the wrong assumption, which means put it in chat if I just assumed wrong. But first, if the documentation does support it, you do want to bill it on the claim. And it depends on the claim that you're billing. Now, if you put it on a 1524D, that's appropriate. As I stated, though, if you put a 99 in 24D, then you want to put information in the narrative segment. Same thing for the electronic adjustments. This actually gives you the full electronic claim in the segment and all that pieces of information. For those of you that don't know that, that's the electronic data interchange talk. So if something's broken, you might need that, but not because you're necessarily going to use it. You might need to refer your EDI to our EDI and have them talk it out. So that's what it comes from. On a UB04, please remember that it does go in field locator 44, and it follows directly the procedure code. Someone asked, is there a separate box on the UB04? And there is not that I know of. As far as I know, it's still just the procedure code with that information right there following. Alina, I'm just going to ask, do you have any other information on that?
No, you're correct. It follows right after the code for the service or the procedure that you're doing.
Thank you. Again, sometimes when we think we have all the updates, but how many of you guys have ever been in Medicare for more than, I don't know, 5 minutes and seen the number of updates that come through? So I just wanted to, again, verify that something hadn't changed that I didn't know about. Well, thanks, Aline. All right. So if you're making sure that your modifiers are appended there, we're good. That's what we have to offer for the presentation and all the different websites and things like that. I do want to start with the pre-submitted questions, and then we will follow up more with unanswered questions in the chat. So here's a great time to put them into chat while I go through this. Okay. The question is, how do the modifiers impact the documentation? And I'm going to give you an answer from one of our clinicians. She always says, if a modifier impacts the documentation wasn't right to begin with. The documentation should support the use of the modifier as written by the person performing the service. If they fully write what they did in an understandable method, that will support the use of a modifier. If you're going back to them to get them to document something so that you can append a modifier and Medicare finds out about that, it could be looked at as fraud or abuse. Now, this is different than when you go back to someone and say, hey, you told me you did, or you mentioned that this happened, or we see a note here, but you didn't expand on what that note means. That's an addendum. Perfectly okay. So hopefully that makes sense. Yes, we allow addendums. We do not want you to do an addendum after we've given you a finding. That does not make sense. That looks again like fraud and abuse there, okay? So if your documentation is standalone, that's what you want to start with. Also, though, remember that when we look at that standalone documentation, we are looking for what makes it significant, what makes it separate, what makes it a different anatomical part, something to tell us why you did this and why you're trying to override this National Correct Coding Initiative edit. The next question is very simple. What's changed? And the answer is really not anything has changed. The edits, of course, are updated, and they're updated based on the procedure codes, the AMA updates, all of those kinds of things. But overall, what CMS is editing for, what we're looking at hasn't changed on the basics and the definitions. Why are we doing this education then? It is related to the number of denials that we're seeing. So that's why we chose to do the modifier series in general. This is part of the modifier series versus just doing National Correct Coding Initiative edit. Okay. Um, we did receive a lot of questions related to modifier 59 and the X modifiers. Now, this is the one that I said CMS has a specific document out there, and I'm just going to reopen this. Um, so bear with me 1 second. The reason that I do reopen this is because in this document, which is an MLN or Medicare Learning Network booklet, and these are the X modifiers, and some of you may be familiar with them. Some of you may say, well, I don't use them. That's okay. Why? Because CMS says you can always use modifier 59. Then goes on to say, okay, let's give you some examples in the booklet. Here's the definitions, and I'm just scrolling down to get to my examples here. Here's some appropriate use things you might want to know. So first, one of the things I want to make clear, CMS does tell you to use the anatomical modifiers when applicable. Okay. Now, I didn't go through every single one of the anatomical modifiers. I understand that. There are some more listed right here. If you're interested in those, I really do think you should take a look at these. But I want you to notice right here, you can use or. CMS does not say you have to use the XS or. The or simply means it's your choice. So if you're confused over this, if you're having issues with this and you're saying, I really don't know where to go, use the word or and just choose the 59. It's not wrong to do that. CMS would like you to use the X modifiers. We understand that. But if it's confusing and you don't understand, default to 59. Again, 59 is that last resort modifier. Shouldn't be used unless no other modifier fits, with the exception of the X modifiers. If you're really confused over using them, go ahead and use the 59. That's your default last option choice. On the other hand, if you say I could append this XS or I could append this 59, just not sure which one to go with, then go with the XS. Okay, so you have no concept, it's not working, something just 59 it is. But I believe it should be this X modifier, or I know it should be this X modifier, but does CMS really want me to do that? The answer is yes. That's a more specific modifier. So I know it kind of wrapped around a little bit there, but remember, you are able to do both. I'm just going to kind of scroll down because we had some more questions and I want to make sure I hit all of them. This one. Other specific modifier uses. Please take a look at this. There are 3 other limited uses when reporting these two distinct because they're separate in time and described by non-overlapping services. I think this is pretty relevant. Again, it's the non-overlapping services that becomes key here when you're using these. They were separate times, they were separate and distinct procedures because of, one, they weren't planned. You couldn't say, I'm going to do one at 4, I'm going to do one at 5, and I'm going to do one at 6. That's a planned procedure. We know that was going to happen. That's not really what they're talking about with these ones. I'm not sure what else you were asking me, but I will encourage you then to take and read the ABC down below. ABC down below. So here's just a little bit of, I was asked specifically about a question on the X modifiers with RHC billing. This is what CMS has to say about that. They in no way, shape, or form say use an X modifier. What they do say for RHC is make sure that you're using the appropriate modifier. And then they go on to define that 29 or 59, sorry, 29? No, 25 or 59. Okay, that's when we want to make sure we're billing correctly. So this is just some additional information. I think it's great. I think it does help you out a little bit with a lot of those questions that y'all did ask. We were asked how a modifier affects the outcome for NCCI edits. The modifier is what allows for that additional payment. So it actually raises the allowed amount because it's allowing additional service units. By allowing additional service units or an additional service, it means you're going to actually receive more revenue. Let's see. So when I use modifier 59 for the MUE, it's only when I'm billing over the MUE for units, and that's correct. If you have to bill either at the MUE or under, you don't need to use 59 at all. As a matter of fact, you would bill two lines typically when using the modifier 59 to override an MUE. And the reason you would do that, especially on those line edits, is simply to say, hey, I did 4 here, but I did a total of 6 and MUE set at 6. So I bill 1 with 4. That's our first allowable. And then by putting the modifier 59 and billing a unit of 2, you're now making 6 total. So you want to make sure that you always have the one without it if you don't need it, or to get the first sets paid. All right. We talked about this one real briefly, but somebody was mentioning, again, add-on codes and whether they should be appending a modifier for this. When an add-on code has more than a certain number of service, first of all, I want to remind you, an add-on code, just because it's an add-on code by nature, doesn't mean it couldn't have a I'm sorry, not a CCI, doesn't mean that it couldn't have an MUE set at a certain level. And you want to follow the basic MUE, right? You want to follow that. Make sure that you have the two together. So like if you, again, wanted to bill 6, you'd bill 4 on one line, 2 on the second line. Again, same add-on code. The 2 would be modified with a 59 potentially to allow for separate payment. All right, that is my last pre-submitted question. So I'm going to throw it open to Aline and see if we got anything in the chat.
Hi, Tom. Yeah, we have gotten a couple things in the chat, so I'm just going to go down the list and I'll ask them in order. And if there's something that doesn't pertain to today's presentation, you know, like it's not NCCI related, I'll let you make that determination as to, you know, what you want to do with that.
Okay.
First one says, sorry, if a CPT exceeds the MUE limit, but the documentation supports the number of units were medically necessary, and the MAI indicator does not allow appending a modifier to bypass the edit, how should we handle these? Should we submit the units above the MUE with a GZ modifier so the claim will go through and then appeal to try to get the additional units paid? Or what is the correct way to handle these?
You do not need to submit the GZ modifier. You do need to submit the claim. Other than that, everything else is correct. Somebody asked about the why not a GZ? It's not about medical necessity. In this case, it's a different type of edit. But I want to remind you that when you do the appeal, you do want to explain that or show that. The reason that CMS has you do the appeal is by their decision, they're looking at the cost effectiveness of having it reviewed on the front end versus the back end. So is it right more often or wrong more often? And that's why the appeal decision was done. I don't have a lot more information on that. So next question.
Sure. Your next question is, 2 providers from the same specialty. Physician sees inpatient for stroke issues, and the NP sees the same inpatient for wound issues. Does that constitute a 25 modifier as a separate service?
So the physician and the nurse practitioner seeing them for different issues does not need to be modified with a 25, unless somehow that physician, like they have a different subspecialty or something going on that we aren't aware of. But for a nurse practitioner, it is considered a completely different specialty than for a physician. Now, if you're billing incident 2 and both of them are being billed under that one physician, that is a different situation, and that would be possibly need to consider a modifier 25.
All right, thank you. Next question says, can you explain nature of service or procedure? That was in the column for I think the rationale of the edit or something. So do you have a way to explain that?
Sure. There are certain types of procedures that can only be done a certain number of times if you're talking about MUE. If you're talking about the procedure to procedure edits, sometimes in order to do this, it's like what we used to call component. Here's your main code and here's your component of it. That would be nature. Now, if you're talking about MUEs, the nature of the service or their procedure means that maybe you only do it once in a lifetime because that's all they have. Um, my sister had breast cancer. Because she had breast cancer, she had full mastectomies where they took them completely away. Well, by nature of the procedure, how many can she have in her lifetime? Two. Right? That's what you got. So that's kind of where that goes when you come up with that one. So hopefully that makes sense. Aline, do you have anything more to add with that one?
Yeah, I thought that question was interesting, so I went searching for CMS's definition, and what I did find is, and I don't know which set of edits they were referring to, but in NCCI, CMS says the nature of service refers to the essential characteristics, type, or category of a medical procedure or service that determines how different codes interact and guiding whether they bundle or can be billed separately. So I hope that helps.
All right, let's move on to the next one.
Next question. Can you discuss billing 96127 with an E&M code that is unrelated to doing a depression assessment? Some carriers want a 25 modifier on the E&M, and I know it is carrier per carrier basis, but I did not find anything stating you should not use the 25. Am I missing something or looking in the wrong place?
You're probably not missing anything. This is one that can be carrier discretion. Let me make sure I familiarize myself before I speak out of turn, but I think the 96127 Pro. Okay, it is the assessment. I wanted to make sure it was that. I wasn't getting any confused with like depression screening assessment, all those different things. So yes, what we're looking for is yes, can this be done? Yeah, we want to make sure that when you're doing a medical assessment, especially for depression screening, you're using the CMS code for it. Now, there are other assessments which can be done with this brief emotional behavioral assessment, so I don't want to make it seem different. And yes, you can modify that with a 25 for us. So it is a separate assessment. Be careful with that one though. If you're telling me you did a low level E&M plus this, there gets to be a bit of overlap where you really don't have enough to make it separate. And that's what winds up happening sometimes. WPS doesn't have a strong stance on this either way. We do say yes, you can, but we really say go back to your documentation. Make sure if you're doing a low level, it definitely needs to be documented in that manner. And then we trust you to read the documentation and to determine whether or not that should be appended. Again, that's an assumption. We assume that you do it right. If by chance you get pulled in a post-payment review or something else, then we'll determine that later. So. All right. I think we got one more. Eileen, did we get one more question before I jump back to the presentation and move on?
We did get a clarification, and this is considering those two inpatients. Is the nurse practitioner considered a separate specialist when the nurse practitioner and the physician work in the same practice where there is only one specialty?
Yes, they can be, and it is related to how CMS defines specialty, because a physician's specialty cannot be given to a lower level nurse. So a nurse practitioner always has one specialty. If it only has one practice, it's going to be different. Now, again, be careful with incident two. Those have a whole separate set of rules, and we definitely don't have time to get into that today. So, as Lean indicated, that was our last question. So let's go ahead and finish up. The next slide is just for the survey. It's just a reminder. Please take our survey. We want the survey results to come in. I'll have Aline throw a link in the chat. You'll be able to get them via the external site, and that is up here. Okay. So provide any feedback that you have, good, bad, and in between. We want to remind you that there are other information coming out on modifiers. You'll get that shortly. You can check our website and see which ones we're coming up with. Um, when you get a thank you email from us, which is one of the ways in which you can get the survey, please make sure that you read it. Don't just delete it. Thank you email actually contains the certificate of achievement, which talks about one contact hour for this. So you want to make sure you keep that if you need CEUs. So please make sure you're doing that. I will accept additional questions for the next 7 days to wps.gha.education@wpsic.com. Please incorporate NCCI edits in the subject line. If you want clarification on any of the answers I gave, or you want a justification, additional documentation or support, please let us know. Aline did put some of those into the chat. And thanks to her for clarifying some of those ones that I couldn't remember off the top of my head and didn't have the actual answer written down for. So if you do send something into us, please expect an email back. That's how we're going to respond back to you. So thank you for listening. On behalf of myself and Aline, you may now disconnect.